Welcome everyone. Thank you for joining today's webinar, Building Rural-Focused Partnerships in Comprehensive Cancer Control Planning. My name is Ikra Haji, and I am part of CADCA's Geographic Health Equity Alliance. The Geographic Health Equity Alliance, or GEA for short, in partnership with the University of Iowa's Advancing Cancer and Rural Equity Lab, is excited to present today's webinar, which is the second webinar in our four-part Rural Inclusion in Comprehensive Cancer Control Planning series. GEA is a CDC-funded national network dedicated to reducing geographic health disparities related to tobacco and cancer. GEA provides free training and support to state tobacco and cancer control programs and their partners on how to reduce health disparities and improve the health of communities across our nation. We encourage you to visit our website, geohealthequity.org, to learn more and subscribe to our monthly newsletter. Next slide, please. Thank you. So I'm sure we're all very familiar with Zoom, but I'd like to go over a few housekeeping notes. All participants are muted by default, so for general comments, please use the chat box. We will have a Q&A portion at the end of the presentation, so for any specific questions for the presenter or the panelists, please use the Q&A box. This week, you'll receive a post-webinar email with the recording, slides, and registration information for webinar number 3 of the series. And following this webinar, you'll be redirected to a brief evaluation survey, which we kindly ask you to fill out. The evaluation link will also be included in the post-webinar email for those who may miss it here. Letters of attendance are given only upon completion of the evaluation survey. And now I'd like to introduce our presenter. Dr. Whitney Zahn is an assistant professor at the University of Iowa's Department of Health Management and Policy and is a full member of the Holden Comprehensive Cancer Center. Her research employs health services research, social, epidemiological, and spatial methods to address rural cancer disparities across their cancer continuum and to evaluate access to healthcare services. She has a particular interest in reducing cancer disparities among rural minority populations. She also leads the university's Advancing Cancer and Rural Equity Lab. Dr. Zahn serves on the board of the Iowa Rural Health Association and co-chairs the Cancer Prevention and Control Research Network Rural Cancer Work Group. Dr. Zahn, I will pass it over to you now.
Thank you very much, Ikra, for the introduction. And I am today just solely a facilitator for this this webinar. I'm really fortunate, really grateful for a couple of panelists who are going to share from their experiences of being involved in comprehensive cancer control planning processes and engaging rural communities, which is the real focus of today's webinar. So just a little bit of our agenda for today. I'm going to give a brief kind of reorientation to the webinar series and how this specific webinar fits into the broader series. And then I'm really fortunate to have 2 individuals, one from the Iowa Cancer Consortium and one from the University of Illinois Chicago, who worked with the Illinois Comprehensive Cancer Control Planning process. They will each be presenting from their unique perspectives. We'll have a little bit of a panelist discussion that I'll facilitate, and then we'll open it up to the audience for any questions that you may have about engaging rural communities in your comprehensive cancer control planning processes. So our objectives today are to re-emphasize the importance of engaging rural partners in these processes and to identify strategies for engaging partners in all aspects of comprehensive cancer control planning, whether it's the plan development, the implementation of the plan, or the evaluation of the plan. And not just the strategies, but what types of rural partners are really important to engage in these processes. So to put this in context, our initial webinar that was held earlier this summer was focused on defining and describing rural communities and what sources of data can help those involved in comprehensive cancer control planning, what sources of data are really relevant when it comes to rural cancer and identifying those sources to describe the cancer burden, to describe cancer-related health behaviors or screening rates, or other important aspects like the social determinants of health, healthcare workforce, and other things that are important. This webinar recording is available on the Geographic Health Equity Alliance website, and we'll have more information with a lot of links to a lot of those resources in the near future, as well as highlighting some other new resources around rural cancer that have become available since that webinar was held. Today, we'll be focusing on building partnerships to support rural cancer control as part of this webinar series. And then upcoming webinars will be focused on setting rural-focused goals, objectives, and strategies as part of your comprehensive cancer control planning process. And then also identifying and implementing evidence-based strategies for rural cancer control in the future. So those are upcoming webinars that we'll also discuss. And really want to discuss just again briefly why we're here, and the impetus for this whole webinar series is related to some recommendations that came from the National Advisory Committee on Rural Health and Human Services, and a report they released in August of 2019. Requiring addressing rural urban cancer disparities and implementing rural focused goals, objectives, and strategies as part of the planning process, particularly in areas where rural cancer mortality rates are higher. And some work that was done between my previous institute, University of South Carolina, and the University of Iowa. We had some students, myself and some other faculty members, look at plans to see, you know, how is rural being included across comprehensive cancer control plans. And we found that over 2/3 of plans are mentioning rural in some capacity, and about 1/3 of those have rural specific goals, objectives, and strategies. This is at least at the time of the plans that were on the CDC's website in January 2020. And so that's great to see that there is that inclusion of rural, and we want to continue to build upon that and provide resources that enable coalitions and those involved in the planning process to increase the inclusion of rural going forward. And so that's the impetus for this series of webinars right now. So with that, I definitely want to turn over to the stars of today's webinar. That's Kelly Siddick, who's the Executive Director of the Iowa Cancer Consortium, to hear her perspective from the development of the Iowa Comprehensive Cancer Control Plan, as well as Dr. Leslie Carnahan, who's a research assistant professor at the University of Illinois Chicago, who's involved in the development of the Illinois Comprehensive Cancer Control Plan as an evaluator. And I think these two perspectives were really, really helpful from a coalition perspective and evaluative perspective. A state that's more rural like Iowa, a state that has a very large urban area like Chicago and Illinois, and I think that just those unique elements of both the individuals involved in these processes, as well as the different state context, I think will really provide some really helpful information. I know Kelly has some other colleagues who will be part of this presentation and discussion going forward, but did want to give them their introductions. And with that, I will turn it over to Kelly for her part of this discussion. So thank you.
All right, thank you, Dr. Zond. I'm going to share my screen, and hopefully you will all see what you're meant to see. Thank you for the nice introduction, and thanks so much for allowing Iowa to participate in this conversation. It's certainly something that's pertinent to what's happening here, as we are just in the process of revising our cancer control plan. And as Dr. Zond said, we are a highly rural state. And so this is a great conversation to have, and I'm looking forward to learning as well. So as Dr. Zond said, my name is Kelly Wells Siddig. My pronouns are she, her, and I have the pleasure of serving as the Executive Director of the Iowa Cancer Consortium. My goal for my brief time here today in presenting to you is to give you a picture of the Iowa Cancer Consortium, what we are, who we are, what we do, and how we function, and then to talk a little bit about rural cancer control work specifically in Iowa, and especially about some recent collaborative efforts that have been happening and have led us to where we are today. And then I want to describe a little bit to you about how that's currently playing out in planning for our next Iowa Cancer Plan version, which is in progress. So our mission at the Iowa Cancer Consortium is to advance cancer prevention and control through advocacy, equity, and collaboration. And I'm starting with this image for you all because I really want to make sure to mention this collaboration piece. The theme of rural cancer control work, and especially that as it relates to the Iowa Cancer Consortium, really is collaboration. I hope that after I'm done presenting to you, you'll be able to see how truly important many players have been to collaborative cancer control work in Iowa, and how it's so important to get out of our own space and welcome others in and find ways to collaborate. And just a heads up, in the spirit of collaboration, because what I'll be presenting to you today is a lot of other people's work. So I have the privilege of representing the good work that's happening in Iowa, but this is really many people's work and other people's work. So I want to do them justice, and we're lucky to have a few folks with us today who will participate in the Q&A. Lori Pedig, who is the Director of Cancer Services at St. Anthony Regional Cancer Center and is a member of the Iowa Cancer Consortium Board of Directors. Dr. Mary Charlton, who is an associate professor at the University of Iowa College of Public Health, and she is our president, the president of our board of directors of the Iowa Cancer Consortium, and my colleague Kelly Angel, who is the rural outreach coordinator for the Iowa Cancer Consortium. So those folks will be able to help me answer some of your questions when we get to that point. Very briefly, I just want to give you a snapshot of Iowa. So we have about 3 million people living in our state. I know that is smaller than some bigger cities in other states. And about 35.7% of our population lives in rural areas. And we have the same challenges that many others with highly rural populations face. So as I mentioned, I'm going to start by telling you about the Iowa Cancer Consortium and how we function. So the consortium is our state's cancer control partnership. So I know probably many of you on either are a member of your state's coalition or partnership, are representing, maybe you're a staff member of a coalition or partnership. So and you probably know that they all look very different. Ours is called the Iowa Cancer Consortium. We are a nonprofit organization. We're funded primarily by a grant from the Iowa Department of Public Health. That grant combines state and federal funds. And I do want to mention this, especially recognizing that there may be some of my coalition counterparts out there. Funding, I think, is a big issue for coalitions. And I just want to reference that we're able to do what we do here in Iowa because we are so lucky to have great partnership with our State Department of Public Health, but also we have some state appropriated funds that allow our coalition to be more robust than it otherwise would be. So we get a grant from the Iowa Department of Public Health to do cancer control work, the partnership work, and the plan work. But we are also housed at the University of Iowa Holden Comprehensive Cancer Center. And what that means is that we are set up for really strong and beneficial collaboration with lots of different people at the state and their partners, and people at the University of Iowa and their partners, and then of course, all of the other folks that we're able to engage within the state. So what that looks like for us is, again, we're able to have a very robust coalition. Right now, we have about 530 members in our coalition, including 60 formal organizational members. There are many, many more organizations represented by Iowa Cancer Consortium members. These are just the formal organizational members of the coalition. So what I'm hoping you're seeing already is that our structure is really set up in a collaborative nature. We are already engaged very deeply with different organizations because we are lucky enough to have some additional resources in those state appropriated dollars. We're able to have more staff support, which has led us to have really strong relationships with many, many cancer control partners within the state. Our members represent healthcare, public health, nonprofit organizations. They represent advocacy, they represent research, they represent survivorship. We have a very vast and diverse coalition membership. I mentioned already that our mission is to advance cancer control through advocacy, equity, and collaboration. We do this primarily through building capacity for our members, or trying to help them build capacity, and to connection to others. We have a colleague, a member of the coalition, who created this, like just came up with this phrase years ago that I just love and obviously continue to use, and that's collaborative infrastructure. He said, you know, what a coalition like the Iowa Cancer Consortium is able to provide to its members is a collaborative infrastructure. And I think that's such a beautiful way to explain what we're trying to bring to our members, and a great way to explain what I think has helped rural cancer control in Iowa move forward. For the Iowa Cancer Consortium, this collaborative infrastructure includes things like statewide work groups that focus on specific topics like health equity, policy, radon, screening, and of course, rural cancer control. Building capacity in this collaborative infrastructure for us includes providing funding for programs and projects that implement the Iowa Cancer Plan. We provide conferences and meetings and bring in national and local experts so that people can learn what others are doing and how to apply that locally. We provide communication support. So if we can fill a collaborative communication gap, like providing social media message sets to all of our partners, so that people are sharing the same and evidence-based messages, we will try our best to fill that gap. And then the network itself, having a network of 530 people really provides a collaborative infrastructure in itself. I think of every link in that network, every connection, as an additional opportunity for growth or expansion of work. And so part of what our staff does is really tries to make those connections stronger or build new connections within the network so that people can find collaborators and resources. So I know we're talking about planning a little bit today. And as I mentioned, we are also, the Iowa Cancer Consortium is also charged with revising, writing, and implementing the Iowa Cancer Plan. Our current cancer plan runs through 2022, which is this year. So we're winding up and we're in the final days of revising for our next cancer plan, which will run from 2023 through 2027. And here in a bit, I hope to show you how our rural cancer control work that's happening in Iowa will inform that next plan. So over the years, recent years here in Iowa, it sure seems like there has been a new collaborative focus on rural cancer control. And that's where I'd like to head next, specifically to rural cancer control. I'll try to describe that evolution briefly. So I mentioned my colleague, Dr. Mary Charlton, who I hope will be here for the Q&A section so that you can ask her questions. Dr. Charlton and her colleagues at the University of Iowa College of Public Health have been absolutely instrumental. And I would say that anything I talked about today, you can probably trace back to Mary Charlton. She really has such a passion for rural cancer control work. She has a very collaborative mindset and has just done amazing work. And I think of her very much as a catalyst for the work that I'm talking to you about today. So the goal of her research in recent years has really been to engage rural hospitals in Iowa and hospital community partners in cancer prevention and control projects. So we know that community hospitals in rural areas play a really important role in providing care to Iowans who otherwise might not have access, but they face barriers to providing comprehensive care due to lack of resources. And so Dr. Charlton's research, again, which I think of as a catalyst, has really focused on providing support for those hospitals. I'm going to very briefly highlight some of her research that really has started pointing us towards collaborative cancer control even more. I will make sure that we provide her email address here in a little bit so that if you have questions specifically about her research, I know she would love to talk to you about it. But these are key pieces of research or research projects that she's been working on that have really led to our work, our collaborative work. So first was an NCI P30 Cancer Center Support Grant Supplement at the University of Iowa Holden Comprehensive Cancer Center, which is the only designated comprehensive cancer center in our state. The goal of this P30 supplement was to build capacity for cancer prevention and control research and implementation of evidence-based programs in underserved rural communities. So to do this, Dr. Charlton engaged 6 critical access hospitals in Iowa and provided them with data that they may not otherwise have as easy access to. They also, Dr. Charlton and her colleagues also identified community partners, and they piloted community cancer prevention and control activities and studies. So what happened was, or what this grew into then was lessons learned that could inform future cancer control planning, including the 2023 Iowa Cancer Plan. It also led to Dr. Charlton developing the Iowa Rural Cancer Collaboratory. So this is housed at the University of Iowa. It's a partnership of clinicians and researchers alike who have shared goals, again, of supporting and engaging rural hospitals. So for example, one of the projects that this group has worked on is educational sessions on things like grant writing for rural hospitals, genetic counseling, symptom management, QI and screening. And because Dr. Charlton already had such great relationships through her previous work, this has been a natural next step in engaging partners, working with the rural hospitals themselves, trying to understand and identify their needs around evidence-based cancer control practices within their hospitals, and then providing support for implementation. And then finally, I'll mention Dr. Charlton's recent R01. So the objectives of her R01 have been to basically study a model that was started at the Markey Cancer Institute in Kentucky to develop a network of community cancer centers. And so this here in Iowa, it's called ICAN. She's working with 4 rural community cancer centers in developing resources and programs, again, tailored to the needs of the individual member hospitals. And they're very focused on Commission on Cancer accreditation and standards, and helping rural hospitals meet those standards, retain or renew or seek for the first time COC accreditation. So that's like the foundation point for a lot of what I'm going to talk to you about. So Dr. Charlton and her colleagues have been doing this research and it have been wonderfully collaborative with others in the coalition and other partners throughout the state. And it became clear that one way that the Iowa Cancer Consortium could partner and provide support is through some sustainability and maybe a little bit of expansion of those engaged partnerships. So the consortium was able to write a grant with Dr. Anjali Deshpande and Dr. Charlton, and Dr. Deshpande is also with the University of Iowa. We wrote a grant to the Intelligent Community Initiative and received a grant for 1 year to develop an infrastructure to basically start a rural work group within the consortium. So we knew if we could get one started, have some foundational support for that then our staff at the consortium, along of course with partners at Dr. Charlton and Lori Pedig, would be able to sustain that into the future, into future years. So one thing, we were successful in that grant and started the work group, which will be housed and is housed at the Iowa Cancer Consortium. And one thing that this was able to offer is that it expanded partnerships beyond rural hospital administrators and providers, but to other rural cancer advocates and clinicians across Iowa. And we're very lucky because Dr. Charlton and Lori Pedig co-chair that group as well. So it was really a way that we were able to work together. And I think of work groups, as I mentioned, very much a part of that collaborative infrastructure. So this is something that doesn't need sustained grant funding. We will be able to maintain this into the future. I also want to mention that at the consortium, our staff is really always focused statewide. Obviously, that's really our mission, is the state of Iowa. But within the past couple of years, we, recognizing the value of focusing on specific populations in Iowa, we've engaged with a couple community contractors. So these are folks who work 8 to 10 hours per week. And are contracted with the Iowa Cancer Consortium. And one of those folks is my colleague, Kelly Angel, who I mentioned will be on for Q&A. And her focus is only rural populations. So this is really a way that the consortium has tried to use some of its funding to focus more on populations that face disparities. So we engaged with Kelly in the middle of last year. She is now our staff lead for the rural network and focuses solely on building partnerships within rural cancer control. And then also I would be remiss if I didn't mention that one other thing that Dr. Charlton has been wonderful at is recruiting board members to the consortium, which again is another piece of our sustainability and important representation in the consortium. And so we're so pleased that this year Lori Pedig has joined our board. And we have also had the engagement of another rural cancer administrator who is also on the board this year from a different part of Iowa. So certainly getting that engagement has been important in ensuring that we have that collaborative infrastructure in place. So today, the Iowa Rural Cancer Network, or the Iowa Rural Work Group, has 114 people on its list, about 20 regular attendees, but 114 people getting the communications. It's chaired by Mary Charlton and Lori Pedig. It's made up of a balance of professionals, as I mentioned. And they are working together on building those connections, whether it's through other administrators and providers in rural Iowa, or developing a list of patient navigators as resources, social workers, or other community health workers, making sure that those folks are connected and can find each other. So building those links in the network. So again, we're talking about planning, and everything that I've described to you, I think of as kind of a lead up to informing things like the next Iowa Cancer Plan. So again, our collaborative infrastructure to inform planning. And so we are in the middle, actually, we are in the end of revising our Iowa Cancer Plan. And we will use Dr. Charlton's research, the experiences of that Kelly Angel is able to provide, and the new partners that she brings in, Lori's experience as a cancer services director, and other members' experiences from the rural work group. We can use that group as a resource as well, to inform our cancer control plan. So for example, some special areas of focus for this next plan will include access to screening and early detection for rural Iowans, supporting cancer centers in their accreditation, whether that's Commission on Cancer, NCI accreditation, enrollment in clinical trials, making sure that people have access to care locally, but can also access specialists in other locations and then be navigated back to care locally. And of course, quality of life, wellness and support services for folks who are living in rural Iowa. So these are my three friends that I brought along, who really are the experts here today in the things that I've talked to you about. So again, Mary Charlton, Laura Pedig, and Kelly Angel, who will be happy to join me for the Q&A and can provide great information for you. In the meantime, I have my contact information as well. They're up at the top, and I'll be happy to share slides when we're done. But that is all for me for the moment.
Thank you very much, Kelly. That was wonderful. I appreciate you sharing what you all are doing with the consortium, and really grateful to have others involved as well. Thank you for inviting them to join. We'll transition to have Dr. Leslie Carnahan do her presentation here, and then we'll do some panel with some questions and open it up after that. So I'll turn it over to Dr. Leslie Carnahan, University of Illinois, Chicago, who's worked with the Illinois plan. So thank you.
Hi, thank you so much. Can you see my slides okay?
Yes.
Okay, great. So again, I just want to echo my appreciation for the invitation today to speak to you all. So I will be talking about our experience in Illinois in terms of engaging rural populations in our cancer partnership, in our cancer plan that was just published. So I'll be talking about multiple approaches as well, and hopefully other folks working on cancer planning can take into consideration some of what we did. So just a little bit about myself. I'm at our University of Illinois Cancer Center and our Community Engagement and Health Equity Office. I wear in the public health space, as I'm sure many of you do, I wear a lot of different hats. So I am an evaluator for the previous funding of the Illinois Comprehensive Cancer Control Program. I also do some public health consultancy work for the Illinois Department of Public Health regarding our breast and cervical cancer program. And then I've also served as an evaluator on multiple IDPH, or Illinois Department of Public Health, CDC funded programs, of which again, our Comprehensive Cancer Control Program is funded through that mechanism, as I believe yours is in Illinois as well. So I have nothing to disclose. So Illinois, right? We are neighbors of Iowa. We look a little bit different in terms of our populations. And I don't think we have as large of a proportion of rural populations in our state, but we do have in Illinois, of our 102 counties, 80 of them are considered rural. And this equates to about over 2 million individuals in our state who are rural. So while it's not, it's less than 20%, it's still quite a few people in Illinois. So obviously considerations of rural populations are very important to our cancer planning efforts. So again, today I'm going to talk about this in a little bit more of a retrospective perspective, because our cancer plan again was just completed and published. But again, I'm going to be talking about, as Kelly also did, a little bit about rural engagement in our Illinois Cancer Partnership. And our Illinois Cancer Partnership is our coalition in our state, which works with the Illinois Department of Public Health to create the cancer plan. And to it's our state led coalition. And then I'm also going to talk about, for our cancer plan, again, that was just published, our development of a community engagement strategy, which included community members at large, but also we had a very intentional effort to ensure that we engage rural folks in our community engagement efforts. And then those community engagement efforts, which included a town hall and a series of focus groups, among other things, to talk about the ways in which we wove this into our cancer plan document. And then again, specifically how we highlighted rural folks in our state specifically. So like Kelly mentioned, so our Illinois Cancer Partnership, it has about, I think the larger listserv has about 580 individuals. And then we have a smaller executive committee, which includes about 20 individuals from about 20 organizations throughout our state. So back in 2020, There was some shifting in leadership at the Illinois Department of Public Health in terms of the individuals running our Illinois Comprehensive Cancer Control Program. And in this shift, it really led us to re-examine on the Illinois Cancer Partnership Executive Committee, who are the individuals who are on that listserv, and who are the individuals who are on the executive committee who have a seat at that table to talk about planning in the state. And so in looking at that membership list on the executive committee, we identified some gaps, especially in terms of rural representation, so organizations from rural parts of our state. So at that point, within the executive committee, we used our own professional and public health networks to really reach out to individual leaders in the rural cancer prevention and control space to invite them to join our executive committee. So that's one way, right, from that larger perspective of ensuring rural engagement and the voice at the table for our cancer plan. So also too, in this pre-planning period to get things ready to write our 2022-27 plan, the Illinois Cancer Partnership, the executive committee sent out a survey to our larger, almost 600 member listserv to get feedback on what people wanted to see in the 2022-27 plan. So this was a very broad survey, but it was very clear from the responses that we received that individuals were really looking to have rural specific information in our cancer plan, because in the previous iteration, there wasn't such an intentional call out of specific rural cancer concerns, rural populations and things like that. So the Illinois Cancer Partnership Executive Committee heard that loud and clear, that there really needed to be a space in our cancer plan that was focused specifically on rural populations in our state. And then for the other, and this is again where I'm wearing my Count Cancer Evaluator hat, we work a lot with the Illinois Department of Public Health and the Illinois Cancer Partnership to do a lot of surveying of our membership. And so in all of this surveying, and I'm sure most of you all do this, but we always make sure that we collect information about the spaces in which people are living and working as it relates to cancer prevention and control. And in our membership engagement survey, which is an annual survey that goes out just to, again, kind of see where people are at in terms of wanting to participate in the Cancer Partnership. And again, we really just try to understand where people are coming from in our state. And so this, again, just allows us to understand the geographic reach. So that's, again, from the broader perspective of how we try to ensure rural representation at the Illinois Cancer Partnership from an organizational level perspective. So then again, like I talked about in Illinois, our cancer plan for 2022-27 was just published. And so starting in about late 2020, early 2021, we decided that, right, in terms of community input to our cancer plan and engagement, of course, we had individuals on our executive committee or a part of the Illinois community, but we really just wanted to use more qualitative public health sort of research and assessment methods to understand through a town hall and a series of focus groups, rural community members' perspectives about cancer control and prevention in the state. And so this is where, in my role at the Community Engagement and Health Equity Office at the University of Illinois Cancer Center, we had the staffing and the expertise and the funding to be able to engage folks for these town hall and focus groups. And I think, again, Kelly mentioned a lot about the funding mechanisms of these coalitions. They often don't have a lot of money. So the Illinois Department of Public Health didn't necessarily have, again, that skill set, expertise, and funding to be able to engage people and compensate them. Because again, we know that financial barriers can be, or financial compensation or lack thereof can be barriers to people participating in these types of efforts. And so again, I bring this up just to say for all of us working in this coalition space, right? Recognizing which partner has which resources and what each partner can bring to the table. And so as a part of our community engagement partnership goals with IDPH, with the Illinois Cancer Partnership, with the CHE office at the UI Cancer Center, we came up with a very intentional strategy to engage diverse stakeholders, again, in a town hall and a series of focus groups. And the purpose of this was to, again, receive input on cancer needs in the state, with then the intention of integrating that community input and feedback into the actual cancer plan. And so this is very broad, right? But through this effort, we really wanted to make sure, again, listening back to that feedback that we had gotten in that pre-planning survey, that folks were really wanting to make sure that rural populations' voices and concerns and assets were highlighted in our plan. So using, again, going back to our coalition's rich network, we used our ICP membership to help us recruit for our town hall and focus groups. So again, thinking about almost 600 individuals throughout the state, helped to try to recruit people to these town hall and focus groups. And we specifically sent in this information to agencies serving rural populations. And then within our focus groups, we did purposive sampling, meaning that we took information of interested individuals and then we put them in groups. We had, for example, one group specifically for cancer survivors, one specifically for caregivers, and then we also had one focus group specifically for rural residents. Again, recognizing that that was a specific population we wanted to highlight. And then in terms of soliciting feedback from individuals about their cancer needs in the state, our town hall and focus group guides that we created included considerations of place. And what do I mean by when I say that? This model here that I'm showing you is the model for analysis of population health and health disparities. Again, it's really a model similar to like a social ecological model of understanding health disparities through everything from social conditions to the social context, but also the physical context. And I'd be happy to share these focus group discussion guides with folks after the call. But again, just to really ask folks to think about how where they live affects their cancer needs in this state. So with the focus groups that we had one town hall, and I could give more specific data on that later, but our focus groups, again, thinking about our intentional recruitment of rural folks. We had 53 individuals who participated in 8 focus groups, and about over a quarter of them were rural residents. So again, we actually oversampled in terms of comparing our state population proportion of rural residents to include more rural folks in our focus groups. And over half of our focus group participants were also cancer survivors. And this map that I have here on the right, it shows you where we had participants represented in our state. And Illinois as a whole is, again, if you remember, about 80% of our counties are rural. So we had folks from all over. So we collected this information, engaged rural populations in our partnership and these focus groups in town hall, and then we got to writing our cancer plan. And I should say, I'm talking about these things as very individual events, but there was a lot of iterative back and forth with the partnership over the course of collecting the data and over the course of writing the plan. So in our cancer plan document, I'm going to talk about all of the ways in which we have addressed rural populations and really tried to highlight the differences that of things we might need to attend to and be more cognizant of when we're thinking about rural cancer prevention and control. So again, I know Kelly was also talking a little bit about the goals and objectives in your plan. We really made sure that we highlighted rural specific strategies to address all of our priority area goals and objectives. Again, recognizing that rural people in Illinois may need different responses to different cancer-related challenges. And then in our cancer plan, we have a standalone rural health section. So this one just gives an overall view of the landscape of rural Illinois, some of the demographic characteristics of the state. And then it also describes some of the rural urban disparities to just highlight and bring that to attention for people engaging with the plan. And then finally, there's information about building healthy rural communities and reducing disparities. So hopefully some information to help people take action. And then again, going back to that town hall and focus group community engagement efforts that I was previously describing. So our cancer plan itself has this community engagement report is also a standalone section. And in this report throughout, we really make sure that we try and highlight the concerns. We tried to highlight the concerns of rural participants and the importance of place and how that impacts people's cancer experience in the state of Illinois. And then finally, in our cancer plan document, we use a number of quotes from these focus groups and town halls to, and it's interspersed throughout the entire document. So again, when in one part of the plan, when someone is talking about some cancer stats, we try to find some quotes from individuals to say, hey, you know, here's the stats, but also here is someone's voice that really reflects again what these stats, what we think these stats are saying to us. And in all of these quotes that we have throughout the plan, we highlight where, in a broad sense, because we wanted this information to be confidential, but we highlight if someone was from a rural part of the state and which region of the state. So again, to kind of bring to attention more specific information. So this one individual who is from rural Southern Illinois said, I live in a very rural part. There are farms, coal mines, and in my small community, it seems like almost every day someone said, oh, did you know so-and-so down the road has cancer? And I think this is, again, just helpful because in Illinois, you know, we're more than Chicago and we want to ensure that everyone's voices are elevated in our cancer plan. So I won't read through all of these acknowledgements, but there's obviously a lot of people who contributed to this effort and to the development of our cancer plan. And I am just, again, very grateful to be able to speak about our plan. And here's my contact information if anyone. Again, like I mentioned, that focus group script, I'd be happy to share that if other folks are interested in seeing what we talked about. So thank you.
Thank you very much, Leslie. That was great. I really appreciated both perspectives from the coalition in Iowa to an evaluator role in the state of Illinois. I think both shared a lot of really great ideas and things that you have done in your respective states around comprehensive cancer control planning. I'm going to ask some questions just to get us started of the panelists, and you all have addressed these to a certain extent in both your presentations, but give a chance to kind of expand on a couple of things. And then we'll open it up to the audience after that for questions. So the first question, and whomever would like to jump in and answer, please do. But the first question is, you know, what strategies have been effective in identifying and engaging rural partners in the cancer planning process? You both have alluded to this with, engaging through research, doing focus groups, but I'd love, if you have anything to expand upon what you've already shared about different specific strategies that have been effective.
I mean, I think, I know in Illinois, again, our landscape of rural versus urban is a little bit different, but talking again, ensuring that rural populations and rurality is highlighted in our cancer plan. I'm again really making sure at the Illinois Cancer Partnership Executive Committee level, right, just acknowledging the role of power in all of these processes. Using that word of mouth, again, public health is a very small, there's a lot of folks who know each other. And so with our group, it was sending someone from the executive committee, sending a personal email to, a hospital representative in a rural community in the state and personally inviting them explicitly, we really want rural populations to have a seat at the table here. Would you please join our executive committee?
I would love to kick it over to Lori Pedig because she is a rural partner that has really stepped up and engaged so much in collaborative cancer control. And I know Lori first started working with Mary through the registry, through the Iowa Cancer Registry. So Lori, what made you want to partner with everyone?
It really was just the by chance meeting of Kelly and Mary, and trying to find resources, making the voice of rural Iowa known, that we're here, we're giving care, we're growing, we're expanding. You know, I don't want to speak for Kelly and Mary when we first kind of touched base, but I don't even know that they knew we were on the radar, that we had been providing care for almost 30 years. Yes, they did our registry, but did they really understand the full spectrum of what we provided here at St. Anthony, and that we were transitioning into a brand new space with state-of-the-art technology and expanding our services, and just trying to really bring those resources to the patients that we serve. Last year alone, we had 15,000 patient encounters through our center, and we cover a 70-mile and 17-county range. So we touch a lot of distance and a lot of people in our area of the state.
I think Mary too. Mary, hopefully you can hear us and can respond, but you know, Mary did, like I mentioned, so much of the partnership building footwork in her research. So Mary, it'd be interesting to hear your thoughts too.
I'm sorry, I was just switching from the video to the phone. Can you repeat the question?
Yeah, yes. Well, Whitney, I'll let you repeat the question.
Oh, sorry.
Sure. No worries. Yeah, the question is just about strategies, effective strategies in identifying and engaging rural partners for coalitions and cancer planning processes.
Yeah, I think, well, I think that kind of the key to my success was really finding people like Lori who are so enthusiastic, and it's just great to find, kind of start off to find some partners like her who are kind of engaged and really well connected. And I was really impressed when I started working with Lori that she already had a kind of informal network of people all throughout Western Iowa who would work together. And, you know, she had already gone to see their cancer centers. They'd been to see hers. They've already kind of talked about some things. And so it was really a matter of finding those people who were already kind of engaged and starting from where they're at and building that network, and then kind of reaching out from there and kind of figuring out who did what in different parts of Iowa. And sometimes it was good to engage, better to engage public health departments. Sometimes it was the hospital. Sometimes they were one and the same, located in the same building. So it was really just a matter of finding some key people and then building on their networks. And we're just really fortunate to have people like Lori who are such great advocates for really connecting people and building these types of networks.
I did write down one statement, and it was that collaboration brings opportunity. If I would not have wanted to work with not only our consortium, but also reaching out to other cancer directors like myself, we're not university, we're not education centers, we're boots on the ground people who wear many hats, and what worked well for them and what didn't work well for them, and learning from each other. And with that brought us opportunity to not only grow, but enhance our patient care, to work on policies, to be part of work groups, and to really improve what we do here in Iowa.
Thank you all. These are great strategies. And this is kind of a follow-up question to that. Obviously, you know, Lori represents hospital providing cancer care. Leslie, you talked about engaging, you know, had a high percentage of those involved in the focus groups who were cancer survivors. So those are examples of types of rural partners, hospitals, survivors. Can you all expand about other types of rural partners who were involved in the process? You know, maybe some that you don't necessarily think of. I know, Kelly, you had a really nice slide of dozens of logos of different partners involved in the consortium, but that might be something I think is really of interest. You know, what types of people, you know, what types of organizations or people that can really contribute to this? Because sometimes there might be groups that we don't always immediately come to mind. So any of you who would like to speak to that, I think that would be great. Thank you.
Kelly Angel, that might be a good question for you if you're willing to talk about the current work group.
Sure. Hi, everyone. I'm Kelly Angel, and in our current work group, we have a really good diverse mix of people. But the work group so far this year, we've been really trying to tap into the cancer centers and what what their biggest challenges and barriers are. Just what are they being faced with right now, that some of those challenges. And many of them said workforce and recruitment and retention, and also transportation. So some unique partnerships that I've seen that we've tried to develop and try to bring in the past is hearing transportation is a concern, and then saying, okay, well, what do we do about that? So getting engaged with local transportation providers and also the state transportation department is a unique partnership that so many people don't think about, but is such a key partnership to develop to tackle such a big structural challenge of getting cancer patients access. We don't currently have a lot of representation on our regular meeting work group in the transportation field, but I do see a sub work group potentially down the road being developed out of that interest in space. But we also did identify a couple of partners this year that we saw on all of the different provider lists of who's working with cancer in the state of Iowa. We kept having Mission Blood plus Cancer. I always say that incorrectly, but they essentially work in a lot of our rural hospitals, and Lori and Mary, feel free to jump in on them. But we just recognize we have Mission Blood plus Cancer working in a lot of our rural centers, but we don't have representation from them on our work group. So we engaged with them. The Iowa Cancer Consortium staff sat in on a 101 type of meeting with them so we could better understand what they did. And then we did bring them on as members of the consortium. And now we have some conversations starting to develop, but familiarity is step one in what I like to do when I'm trying to build these relationships and just grow the work group, is just making us familiar with each other. And Lori kind of tapped on that earlier, of just the familiarity that we need to have first.
Yeah, and I will say, using a similar method, it sounds like that Kelly was describing. So in terms of our Illinois Cancer Partnership, which is our coalition, again, we have an executive committee, but then we have more working groups, subcommittees that really follow along the lines of our priority areas. So prevention, we have a prevention group, we have a screening, early detection, and then we have diagnosis, treatment, and survivorship. And we have talked about with our coalition creating additional work groups. So, do we want to have a rural work group? But I think, one challenge out there is a lot of the folks who participate on these coalitions, everyone is already stretched a little bit thin. And so our rural partners, on this coalition, it's like, oh, you go to these other coalition meetings and you also see them there. And so I think it's kind of trying to respect that space and people's time and energy. But like Kelly was mentioning, for our priority area work groups, we don't have that Department of Transportation partner. Sounds like such a great idea. We don't have anything quite as innovative as that, I would say. But again, I think kind of leaning towards more traditional community and clinical partners. But we did try to ensure that there was representation broadly across the state within those sub working groups that we have. And again, like Kelly mentioned, just really, looking actively for gaps in representation and then actively reaching out, engaging with folks for recruitment to the coalition.
All right, thank you all. Those are great examples of partnership types. There's a question from the audience that ties directly to this, so I'm going to weave it into here. But those in the audience, feel free to put your questions in as you think about them, and we can intersperse them into this panel discussion or have them at the end, either way. So there's a question about were there efforts this is for Iowa or Illinois, to involve migrant farm working communities to provide input? So either state, I guess, would like to speak to that, because I know that's in both states. So love to hear any perspectives on that.
I can speak to that a little bit. So a lot of times in our coalition, we are working with the folks who are working with communities. And so one group that we've been able to engage and sustain a good relationship with is a federally qualified health center called Proteus here in Iowa, and they work quite a bit with with migrant farm workers. So while, for example, our staff and potentially our board haven't necessarily engaged directly, we're doing our best to keep relationships with the folks who are serving those communities and can make sure that they're represented.
Yeah, I think we have also taken, that's a great suggestion, and I think something for us to consider in the future. But like Kelly mentioned, yeah, we've been connected with a lot of FQHCs. And then, although not comprehensive enough by any means, again, kind of having some of those financial and time constraints with our, some of our focus groups. Again, we did have the rural specific one, and then we had another one specifically in Spanish language, but which was folks from across the state, but we did have some rural Spanish speakers. So again, don't want to equate that to a particular job and industry, right? But we know in Illinois, thinking about where some of our rural immigrant farmers live, it is obviously our rural part of our state.
I specifically had 2 patients come across our desk here at St. Anthony that fit in that population. And one barrier that we found is there's screening opportunities and funds available. But when both of those patients were diagnosed with cancer, they had a hard time getting a facility that would take them on to take on their care. They didn't have access to insurance. They weren't maybe in the systems. And so that really became a barrier for both of those patients. And I worked closely with a coordinator trying to provide and find those patients opportunities to get the care, because they got the screening, they got the diagnosis, and then now what? Because there's not large amount of funds unless you've got charitable endeavors within your organization to take on those patients. And both of them required surgical consultation and some follow-up treatment. And that really was a challenge. So, when dealing with the migrant population is how then do you provide them the care that they need, maybe when those financial resources aren't there.
Thank you. This is a somewhat related question, but I think types of partnerships is, I think, really it's interesting to hear about those. Another question is, have you all done any work with non-traditional rural partners, for example, Farm Bureau, agricultural associations? And if so, how did you make that work successfully? So whomever would like to speak to that, love to hear that.
I'll defer to you all for that one, because I don't think we had quite the rural reach in Illinois as you all did in Iowa.
Yeah, so a couple things. We have a lot of folks who are connected, again, with groups who are very specifically looking at health issues within populations. So for example, the Iowa Rural Health Association obviously is connected with groups like that. And we do a lot of cross participation and connection with groups like that. The groups specifically mentioned are probably areas of opportunity for growth for us and expansion. Kelly Angel mentioned the transportation connection, and that is one place I think that there has been some really innovative work done with non-traditional partners. And Kelly, I don't know if you're able to provide, the work is huge, but a quick 1-minute summary, and then maybe, I don't know if Mary or Lori have other input.
Yeah, real quick, I'm gonna pop a link in the chat that one of our rural partners that I worked with for a transportation grant under the Iowa Consortium. We did talk about how do we engage, the partners like our transportation partners, because they just serve so much. And so health appointments is not their number one, but it is a huge part of what they do. This is HERDA in the state of Iowa. They serve multiple counties, and one project they started to work on is just simply almost like a quality improvement project of, do you have transportation? So when a patient's making an appointment with either a healthcare provider or anyone, HERDA, actually the transportation provider, is the one who said they really should start asking if they have transportation. Thank you, Kelly. But HERDA is the one who really is challenging people to do that. So they created some small materials around that, like some sticky note pads with reminders. And it was just a really neat, unique way to start thinking of when people are making their appointments, especially our rural patients, have they thought about how they're going to get there? And that's just a critical small piece of, that's very in the weeds of how we work with our transportation partners. But in the state of Iowa, there is a state coordination council, and I used to sit on that, and that's how I got to know a lot of our partners. And so I've seen them really change their thought processes on how are we working with our chronic care patients. But it took a voice of engagement and advocacy to really explain cancer care to them, and to really explain how, cancer patients, they can't wait 30 to 40 minutes past their appointment to sit there for their ride if they're maybe not feeling well, or they are immunocompromised. And so it was just really cross-educational to work with their industry, bring them into the cancer world, and then vice versa for our cancer providers to really educate our transportation providers. You'd think these people would be talking, but they don't. So the Iowa Consortium really gave them the space to do that, and it was a rich opportunity.
Thank you. As questions come in, I'll prioritize those over the ones that I have, because we could just plug those in as people are thinking of them. So this one's more directed at the Iowa group. And Kelly, you touched on this, I think, a little bit in your presentation, but can you talk a little more on the funding of a rural outreach coordinator, like Kelly, two Kellys? Yeah, the funding of that position. I think this kind of ties to a broader question that I have about, other things you could share. What advice do you have for programs in general to, address rural things? And this might kind of tie into that. So.
Yeah, you bet. Thanks for the question. And honestly, this is why I mentioned at the beginning of my presentation how we are so lucky here in Iowa to have state appropriated dollars that support especially our coalition here in Iowa, because it really, it hurts my heart a little bit to go out and talk about all the wonderful things that are able to happen in Iowa, but to recognize that it is really because we are able to tap into additional dollars that a lot of states are not able to, at least as of yet. We can be hopeful, right? Maybe we can serve as a model for some advocacy for other states, but specifically to talk about, so the simple answer is that we fund our community or outreach coordinators like Kelly, and then another coordinator that we have named Georgia Hodge, who works with Blackhawk County, Iowa. We fund them from our programmatic dollars, from the grant that we get from Iowa Department of Public Health, our 5-year comprehensive cancer control coalition grant. So it is our same programmatic dollars that we do almost all of our programmatic work with. That said, some important context that I feel should be added is that, we, like all organizations, have occasional staff turnover, and our coalition especially we try to be very nimble. And so sometimes that means, we're taking advantage of grant dollars here that fund a staff position. And then when someone leaves, for example, we have to reconsider where the grant dollars are going. And there's just a lot of moving pieces. So this particular effort, so this thing we're trying, which is smaller time community contractors, smaller FTE community contractors, is something that came about because we recognized that when recruiting for full-time positions or half-time positions, which is what we might have had space for in our budget the last time staffing changed, we just were not getting, we were getting people from our local area. So we're in Iowa City, which is a more urban area in Iowa and a very different animal than most of Iowa. So we were getting folks from this location who were, you know, often embedded in the academic center where we are embedded, you know, so we were getting a lot of people who were just very much like the rest of our permanent staff, and that's not what we wanted. So there was just something about recruiting for that permanent position through the university that was really keeping our staff very the same, homogenous, right? So part of the effort, the reason we did this was we diverted some salary support that had been used for a position that someone had left, and instead decided to use it for contracted positions. And then we're able to recruit people in communities that were not this community to provide, and who were familiar, more familiar than our current staff members with the work or the needs and the people in those communities to do the work directly. I don't feel like I said that super clearly, but it was definitely like a decision to change how we were spending that money on staffing so that we weren't getting, so that we had more diversity of representation on our staff. Hopefully that was clear.
And if I can just chime in, I think this like question of funding with the cancer plans is a very important, and it brought not just in terms of staffing. Illinois, very similar. It's a, it's a very small program of two. CDC budgets are cut for these programs continuously. We don't have matching state dollars. And also with our cancer plan, I think it's really important to note that the funds don't necessarily go towards implementation of actual programs and services and things like that. But that's where, again, thinking about this from a partnership lens, when I'm wearing my cancer center hat and we're in an academic center, we have more funds readily available to contribute to these efforts than the Illinois Department of Public Health has. So I think that's, thinking about that from an access and equity perspective, thinking about on our coalition, we have some other organizations that are very generous and will, help back pre-COVID when we were doing more in-person partnership and coalition building things. We had some of our partners help support and fund, an in-person event in Southern Illinois. So not always having the events in Chicago. But yeah, I just wanted to chime in a little bit about funding because it's always a challenge, unfortunately.
Thank you, Leslie. I think, yeah, funding is always a challenge. And I think that's true of comprehensive cancer control programming. People do a lot of great work with limited funding. One question I have, and again, the audience, feel free to put any questions, continue to put questions in the Q&A section. So one question is, what advice would you all give to comprehensive cancer control programs, coalition partnerships to effectively engage rural partners? You kind of addressed this in some ways throughout, but just maybe this is a more targeted, specific question on just advice you all have, or things you have learned, or things you've learned to do, or things you've learned not to do that have been effective. So whoever would like to jump in with that question, welcome your perspective.
I guess I can jump in. I would say the biggest thing that I learned over the past few years is just how important it is to approach people in the community as partners, especially when you're coming from the academic medical center in your state. I'm sure I've learned probably as much or more from Lori than she's ever learned from our group, and similar to the other partners that I've had, and really come with them. Like I basically went to them with data because I knew that's what I had, and that would be helpful. So I didn't go just sort of asking right out of the gate for things or for engagement, but really tried to bring something to the table right away and then find out what else we could do to be helpful, to make it a mutually beneficial partnership and make sure it was worth everybody's time. And I think that approach has been really helpful over the years.
One of the very first things I kind of learned and discussed in working with Mary and Kelly, and now the other Kelly too, is that being rural is really considered a disparity. It wasn't something that was brought to the forefront of what we provided here at St. Anthony, but that, you know, providing rural health care, there are limitations, and it's all about increasing that access and good access to quality care. And the University of Iowa is on the opposite side of the state, and making sure that our voice had value. Our voice hopefully brought something to the table that they never thought about in some of our educational opportunities. We working and collaborating with some of the physicians from the university. I hope that they got the value of what rural healthcare does and understands, and how we function differently than a university setting. But then that improved the communication and the opportunities for all of us.
This isn't necessarily specific to rural engagement, but it's just something I think about a lot lately. I'm lucky to have been with the consortium long enough that I can start to think in big chunks of years and see patterns that happen over time. And I think it's really hard. It's very difficult, especially in a grant-funded world where we're working on, you know, a year of a grant project period, you know, where we want to see idea, implementation, evaluation report in a year, you know, or whatever it is. But something we really have to keep in mind, and I think we have to advocate for as people doing collaborative work, is that the collaboration is a long game. And I say that because it's really important to just be taking note of what's happening, you know, with partners. And even if there's not something developing out of it at the moment, chances are that there's something that you're watching, or that you could be watching, or a partnership that you could be nurturing, that will develop into, like, can develop into supporting another initiative, or somebody, you know, you'll find a connection between the two. And so if we can advocate for ways to sustain work so that we can play that long partnership game, I think we're going to do a lot better overall in cancer control. I mean, if you think back to what I presented, I mean, Mary's research started years ago. Iowa has been a rural state for how long? Ever. And Mary's research, you know, there has been plenty of rural research, but the research that ultimately led to lots of this engagement and Mary's work, you know, really started a few years ago. And we're really just getting to the point where we have the deepest, I feel like, the deepest connection across the state, and ability to move forward with lots of different types of partners. So it's a long game. It can be frustrating in the short run, but don't worry if you're feeling that way, because it is a long game.
And I can add to that a little bit, and I think this blends into a question that was in the chat. As you mentioned, with all the cuts to CDC funding, there's an expectation to rely on partners to get work done, but right, everyone has their own work to do. Any thoughts on how to address this, and/or help funders understand that partners have limited time, and it's a bit unrealistic to expect them to help with no funding? That's a great question. And I think going back to what we do in Illinois, specifically with our Illinois Cancer Partnership, again, there's almost 600 individuals who are on the broad listserv. But when we talk about engagement approaches with individuals who are on the partnership, we ask everyone to complete a survey that asks them what type of involvement they want to have with the partnership. So if someone indicates right, they want to be on the executive committee, or they want to be more than just a recipient, a passive recipient of emails, you know, so they want to be on a working group. And then again, we ask folks, so not that if someone volunteers their time, it doesn't necessarily mean that they have it. But then again, like I said, we do this annual survey with the members to check in with them and say, hey, this is the level of engagement, involvement you stated you wanted to have. Are you still feeling that way? And then from the leadership perspective, the co-chairs of the Illinois Cancer Partnership, I think they just really try to be clear and intentional with folks who are putting in the work. What is the expected timelines? Can we meet this realistically? So just again, being very transparent about what is being asked of them, because again, it is, kind of one of those things where it's the funding, those folks are volunteers. They don't have their salaries funded from this work necessarily. But again, it's kind of that check-in, this is where we were at. Can you still provide this level of commitment? If not, that's okay. So that's one way we do that too.
If anybody from the Iowa group wants to tackle that question as well, the funding question is obviously a very important one and a challenging one. Are there ways we can advocate for increased funding, or at least a recognition that people are doing a lot of work without that? And that'll be second to last question. I didn't want to give time for the other question that was shared before we wrap up. So, but I'll allow anyone from the Iowa group to speak to the funding question.
I can try and tackle that from a coalition perspective. So first of all, if anybody's interested in the model that Iowa has in terms of whether it's our nonprofit coalition being housed at an academic center and how that relationship works, or what our grant looks like and how the state appropriated dollars were sought years ago, and what that looks like, I am so happy to share that. Again, I really feel that grant funding is not it really is not a growth-oriented funding mechanism. It is not always sustainable mechanism. Granted, I say that from a place of comfort where, from in Iowa, where we have access to more sustainable funding. So I completely recognize that. But if we can help people understand maybe what there is to advocate for and what it might look like, we would always be happy to do that. I don't know. I feel like this is a academic issue. It's a nonprofit issue. This whole grant scramble, constantly needing to prove yourself in a different way every 6 months. It's a really tough spot. And I know a lot of coalitions and programs are feeling it, especially right now. So I offer a lot of sympathy on that, but also if we can serve as a model in any way or provide information or, whatever that is, we'd be happy to do it. And then I'll also share in terms of sustaining, partnerships, our colleague here at the consortium, Rachel Schramm, who's our program manager, I call her the queen of analogies, but she talks about what we do as priming the pump. So it's very, very true that people don't have time right now. People are exhausted. We're all exhausted. We've been through a very tough time, and many people are still going through tough times, and people are burnt out. And two things that I think have sustained our coalition work or guided our coalition from a staffing perspective and what even is our place? What is our purpose here? Are that idea of priming the pump. So we keep the pump warm. So if we have a year in a pandemic where people don't have time to take on new cancer control programs and partnerships, well, then we find out what they do need. And we just keep checking in. We just check in. We don't ask anything of them. We check in. How are you doing? What do you need? What's going on? You want to have a quick Zoom coffee chat just to vent a little bit. We keep the pump primed that way. And then when there's an ask or a need down the road, the relationship is warm still. People feel valued as they are and ready to engage. So priming the pump is a big one. And of course, I've forgotten the second one, but the priming the pump was the important one, the important piece. Oh, being nimble, right? Like I think one thing that having secure funding really provides is the ability to shift and change direction and respond to partner interests and needs. So just being a nimble organization and having nimble people engaged and on your team and in the coalition really allows response to mood shifts, to pandemics, to changes in grant funding from external partners. So I really feel like kind of focusing on those two things has helped us sustain and grow partnership during a pretty rough few years.
Thank you for that. And there's one final question I'd love for the group to address about working with networks of community health workers or Conadoras de Salud. Apologize, my Spanish pronunciation is not very good. On rural outreach and engagement activities. So if you would like to speak to that group of partners, that would be great. Thank you.
From a broader perspective in Illinois, so we're really excited in our state. We still don't know what implementation is going to look like, but we had some legislation passed concerning reimbursement of community health workers. And so there has been a lot of activity, and especially in our state in terms of community health workers. So we're really looking now how to ensure proper reimbursement, right? If there's any training needs of folks. But another specific program in our Illinois Breast and Cervical Cancer Program, which has agencies that cover all 102 counties throughout the state. Our Illinois Cancer Partnership works a lot with our Breast and Cervical Cancer Program, and they have a whole community health worker program. And it's still piloting. It hasn't reached all of the 30+ agencies, but we're doing it in tiered. And we definitely have a lot of rural sites that use community health workers. So again, there's kind of this intra-public health feedback loops that happen with all the cancer players. But again, we're really excited about the legislation, and folks on our coalition that was a part of our American Cancer Society Cancer Action Network Day activities. If you all are part of Iowa's ACS CAN, right? So we put on our advocacy hats and got together for that.
That is so exciting. Congrats. I think that's really amazing. In Iowa, we don't have a solid specific structure for community health workers. And so our engagement with, there really is no formal group, statewide at least. There is an organization that does community health worker training for people who are interested. But our work with community health workers has really been more in a couple pieces. One, our other community outreach coordinator who works with the Black and African American population in Black Hawk County, Iowa, identifies as a community health worker. Again, there is no formal description of what that is. She identifies as a community health worker. That's what her work has focused around. She's a member of the community. And so we've engaged with her as a community outreach coordinator. And then we've funded, so we provide Iowa Cancer Plan implementation grant funding to different organizations that are doing work to support the organizations or individuals who are doing work to support the Iowa Cancer Plan. And we've funded multiple partner organizations who are building community health worker or navigation programs, or expanding community health worker navigation programs. For example, we're funding another FQHC this year to help expand a community health worker program that'll focus on another population. So we don't have that formal structure here. I'm gonna look to my colleagues in Iowa though, in case maybe I'm missing something.
No, I think that's right. Unfortunately, we don't have anything like that here that I'm aware of.
Well, thank you all. In the interest of time, everybody's busy schedules and time, we'll wrap up the Q&A. But I want to thank very much everybody for participating in this event. Really, especially I want to thank our panelists, Kelly, Lori, Mary, and Leslie for all participating in this and sharing the work that's been done here in the Midwest, and really appreciate you taking your time. I'm gonna pull up here the slides. Hopefully I have the slides pulled up for the just a reminder of the upcoming webinars in this series. One in next month in September, focus on rural focus goals and strategies, and then one on identifying and implementing evidence-based strategies as kind of next steps in this process of rural comprehensive cancer control planning. You can see the times there. You can view the past webinar from this series on the website. There'll be this one will be going up later, and we'll be sure, with confirmed permission with Leslie and Kelly on sharing their slides. If they're amenable to that, we'll do that as well as the past previous slides. So with that, unless Ikra has any final closing thoughts, we definitely want to thank you all for your participation today, and really appreciate all the great questions and all the great discussion today. And of course, fill out the survey that will pop up here shortly. And just again, thank you so much for your time today.